All right, Tisha Dean. It is 2:06 Eastern Time, 11:06 Pacific, 1:06 Central. You ready, Freddie?
Yes. I want to make sure we have time at the end for questions and discussion. Do we want to go ahead and do announcements before? Do you want to
Yes.
talk about the conference and all that good jazz?
Sure. You want to start us off?
Sure. Okay, I am not muted. Yay! Um, Welcome everyone. We got about 15 people on today so far. So first of all, we're all excited about the conference coming up in just a little bit, and we do have an intimate dinner that we will be having on Friday night. And Monica has created a sign up for that. So if you want to go, are you going to send it out on the
I'm going to send it to
or
Jackie because I think Jackie is planning on posting it. We were just talking some, so we would love to just have open doors for whoever wants to come. Come, let's chop it up. Let's talk. Let's have some good food. But we are not in a place where we were able to do that. So it is a small group, first come, first serve for the reservations to RSVP for that on Friday evening. And then Saturday morning of the conference, from those of you who are there, we will actually be having a SIG meeting in person Saturday morning, which is come one, come all. So just wanted to make sure to let people know where we were coming from that, not trying to leave anyone out. Want space for the more seasoned collaborative care folks and the newer collaborative care folks and thinking about collaborative care folks, but we just were not in a situation where it could be kind of come one, come all. So I'll be sending that link to Jackie and she will put it with all the normal conference things. So just to know if you are looking for something to do Friday evening at 7 p.m., then sign on up. Saturday morning, our CoCM SIG meeting, is it 7 a.m., Tisha? Am I right? Okay. So Saturday morning at 7 a.m., I will be so happy and chipper just like this for you all at 7 a.m. So Saturday morning is our SIG meeting at 7 a.m. And I don't know the location right now, but that should be in your conference booklet. And then for those again who are looking to just get with some people and have dinner Friday evening at 7 p.m. At is it Domingos? I have that wrong. All the information will be on the RSVP for those who are looking forward or interested in doing that.
yes, we very much looking forward to it. We'll have space for 14 at dinner. So if you're interested, be on the lookout for that. So also I think they're working through the SIG elections processes. I think they're finalizing that, so that information will be coming out in the next couple of months. And so for this SIG, we will be looking for one new SIG leader. So be thinking about that for nominating yourself if you're interested in doing that. I will be rolling off, and Laura Sidari and Monica will be continuing. So I will be sad, but I'm excited to see who will be next. Does anybody have any announcements or things that you want to make sure the group knows about before we kind of get started with our talk today? Okay, well, I'm easily interruptible and welcome interruptions if things come up. I think I can see the chat. What time Saturday? David says 7 a.m. Um, Early morning with our coffee. Um, so today I was going to talk a little bit about some of the implementation journey that we have had in my at my place of work at at UAMS, University of Arkansas for Medical Sciences. And my goal for this was really to have a conversation. So I'm really wanting for you guys to hop in, have questions, us to think through things together. Mostly because whenever I got started, I felt very isolated and kind of on my own and felt like I had to do this all by myself. And also, I thought that, that there was this way of doing it and I was going to do it wrong. And so I think that it's really helpful, and it's been really helpful for me in my journey to learn from other people, to kind of hear about what they've done, and really to be reassured by the struggles that other people have had. That I'm not alone in that, and I'm not failing if things don't go always as planned. So that's really my goal here, is to kind of share this journey, share what's going on so far, and then also to pinpoint the fact that it is a journey and it's very much unfinished. So I'm going to share my screen real quick. Dude. Sure. Can everybody see that?
Yes.
All right. So I've entitled this today, Implementation of Collaborative Care, Tales of a Large Academic Medical Setting. So I first of all just want to recognize that this is a tale, and my tale is different than yours, and my setting is different than yours. And so, all of our journeys are going to look different. And I do believe that we all can and learn from each other's journeys. So as I said before, really my goals and objective for today is to really consider the many organizational moving parts in the implementation of a complex intervention. Integrated behavioral health in general, and collaborative care as a model, is a complex intervention. To learn about the implementation processes in a specific setting, hopefully apply lessons learned to your settings, for us to share strategies for successful implementation, and receive support and validation. So if nothing else, I hope you receive support and validation today. So just a little bit of context. I feel like it's helpful to kind of know what is it, where are we at, and what's happening. So my context is I am a Kansan, a native Kansan from the metropolis of Weiner, Arkansas. Population about 300. So I'm a rural Arkansan. I grew up in Arkansas. I went to the University of Arkansas as a undergrad and graduate student and got my degree from there. Did my internship and still work at UAMS. And I did all my integrated care training, my primary care behavioral health training, in the VA. And so my context is within that model. And in that model, the VA has a pretty robust integrated care where they have PCBH embedded, and they also have collaborative care in some form or another. Also, I'm a kitty mom. I have kitties, and I have a 16-year-old who is driving, and that is terrifying. So this is all happening within this context. The more specific UAMS context, which I think can be really helpful whenever we're thinking about, like, what are we trying to do here and what are we implementing, is UAMS is the only academic medical center in the state of Arkansas. So we're pretty unique that way. And we have primary care clinics in every corner of the state. So if you see all those little stars, those are places where we have our regional programs. We also have multiple clinics that are located in that red dot area in the centrally located part. UAMS, our campus, which is at the bottom, is in Little Rock, which is right in the middle of Arkansas. And then we have those satellite clinics. This is one of them, the one on the top. It is Helena, and that's one of our clinics. It's located in Phillips County, which is one of the most impoverished and uh, low low resourced areas in the country. It's right in the middle of right in the Delta area. So you'll see that's the Mississippi River that it's located on. So that is kind of our context. Any questions about UAMS or thoughts as we kind of start with our context? I'm biased, but it's a great place to live and work. David has a
Tish,
question.
I was going to say, David.
Yeah. Okay, tell us the approximate size of these remote clinics and how they're staffed, please.
Yeah, great question. So they vary fairly greatly, but they're all family medicine residency clinics. So, well, except for El Dorado, not yet because they're brand new, not Magnolia and not Helena, but most of the other ones are residency programs. So they have they do a volume of anywhere from about 800 to 900 to 2,000 patients a month, depending on the size of the clinics. They have usually they have cohort classes of about 6 or 7. Well, anywhere from 6 to I think 9, and they have three classes of residents, so first year, second year, third years. So they'll have like 24 residents, and then they'll have faculty in those positions. So they'll have anywhere from 2 to 10 faculty. Does that help?
Yeah. Yes,
So
it does. Those are pretty big operations. Thank you.
they are pretty big operations. And that is one of the, at the beginning, we talk about the complexity, right? There's so many layers of these different clinics. You've got teaching, you've got, just their setting. Then you've got the fact that, they're in these different areas, which all of these populations have very different needs depending on where you're at. So if you see like Fayetteville, the northwest corner, that is where the University of Arkansas is. That is, where Tyson and Walmart and there's a lot of business and money in that area. And then you've got the southern part of the state, which Texarkana is a pretty big place. But then El Dorado and Magnolia are smaller. And then you've got Jonesboro, which is a pretty decent sized town, but it's a very rural area around it. And then you've got Helena, which is very rural and small.
It sounds like you could do a lot of really great research.
Yes. And we have some mechanisms for research, but we certainly aren't doing nearly as much as we could, for sure. So I'll tell you a little bit about our journey. So UAMS has been involved in integrating behavioral health into primary care for quite some time. They dabbled for a while and then really kind of concerted their efforts around 2015 as the primary care service lines were created. So that I'm shouting out here to my team, my leadership team, Kathy Emons and Ruth Fissel, who are licensed social workers who are managers for the central and regional programs clinics, and they manage a lot of the our embedded providers. But they're the ones who've kind of built this system starting in 2015. And then around 2017, if you guys may have been around in primary care, was kind of the push for CPC Plus, some of the money that was provided for primary care to add team members and to get payments per member per month to do that. And so Baptist Health, which is another medical facility, kind of started with that. And that was another push that we got to get funding to add integrated care. And then I came along in 2021. At that time, The primary care leadership really was interested in growing and building onto the primary care behavioral health team that they had. And so they hired me as the director of behavioral health integration. And then they also hired a psychiatrist at 40%. Her name is Samita Tripathi, to help support integrating further and building the program in 2021. So we had a really good foundation to start from. I want to say is that we had embedded social workers and licensed counselors in most of our family medicine and internal medicine clinics. So there was somebody there, which is a good starting point. We did have really two programs. So we had our central clinics and we had our regional programs. And so these graphs, the details aren't really that important. It's just kind of show the difference in kind of volume and the types of interventions that were going on. So in the central clinics, there was a lot of reaching out to patients after they'd seen the doctor in like not in real time. So a lot of telephone, a lot of patient messages, a lot of sending referrals and helping patients get connected with services. The regional programs was operating on more of a PCBH model, where this purple line are the social work interventions, so billing for psychotherapy. So you see that the interventions were happening in central clinics. Those were primarily in one clinic where they really had it built. The rest of them were usually more of the non-same day interactions and non-face-to-face interactions with patients. So when we were getting started, when I was getting started, really, we've kind of have a 4-step process. And these can be simultaneous steps. It's not one right after the other, but 4 key pieces that I've been focusing on since I got started. One is identifying the care that we want to provide. So what is it that we want to do for our patients? What is it that we want to do in the clinics? So to have a goal of what is it that we actually want. Build a team that is working towards that goal. So we had a great team of people, and we had multiple different goals, and in some not a lot of goals as a group. So we really were trying to build a team of one integrated behavioral health team rather than having 2 separate programs. The other one was creating a plan for implementation. So once we know our goal and we have a team, how are we going to implement and get these goals working in our clinics? And then, of course, this goes along with everything, finding the resources needed, because we all know that resources are scarce, and they have been especially in the medical world, very up and down over the last few years. So how do we find the resources to build what we want to build? And Monica, tell me if I have any chat stuff, because I can't see it.
Will do.
All right. So just a little bit about the ultimate goal. So what kind of program, what kind of intervention, what kind of service are we wanting to build? So going back to my training and experience at the VA, and given the fact that we have very, very, very few resources in Arkansas as far as psychiatry goes, as far as any sort of specialty or behavioral health, we really need to be able to provide as much as we possibly can to our patients in primary care, because in a lot of ways we are the only shop in town. We also are we're a safety net provider, so we don't turn patients away. We get money funding. We're a state entity, so we get funding from the state to support patients that otherwise wouldn't get resources and support. So, a lot of times, even if there is facilities or people in the community, our patients don't have access to them. So really, we wanted to build a a model of integrated care that looks kind of like a blended model that has the PCBH options for people in the clinic ready to get warm handoffs to help patients with helping them with managing their chronic medical conditions, helping to triage and to be there to catch whenever we have patients who are in crisis. And then we also want to be able to provide psychiatric consultation, following patients over time, and provide some of those great services that collaborative care offers for, being able to do telephone work and being able to meet patients exactly where they are. We're a very rural state. Many of the patients that we have to travel a very long distance, and they also don't really have access to broadband. So as far as video, is not really an option in a lot of the areas that we work in, even today. So what we want to do is be able to provide same-day access, functional assessments, population tracking, treatment recommendations, brief interventions, follow-up and referral management. Another reason why I personally and UAMS is bought into providing kind of this blended model is because of our training. It's really amazing for our residents to have access to a psychiatric consultant to help them to think through how to manage primary care patients and to get that support and knowledge. And it's also really great for them to have, our embedded behavioral health consultants are faculty. So they provide didactics and training, and our residents can shadow them and learn from them. And so you've got that great environment of learning for our residents. So this is our beautiful workflow. It's very complex, but really we identify patients either through a registry, so pulling patients in their screenings. Mostly they're identified through our behavioral health, our primary care teams. Then, one of our team members assesses them, either the BHC or the behavioral health care manager. And then either they are enrolled, we call it mental health consultation, just because that just helps the doctors to know, okay, this is our consultant's model, this is our BHC model. If they're appropriate and would really benefit from, the CoCM, they'll go into that model and be followed. If they really, just need support for, weight loss or smoking cessation, or, there's someone that we're following and trying to help get set up with specialty mental health care, or, it's just doing sleep hygiene, then they would continue to just work with our behavioral health consultant. In both ways, we track patients, and if they're getting better, then they go back into our primary care population till the next time they need us. If they're not getting better, then we look to referrals and options outside. So this is ideally what we're trying to get to. Questions about this?
Yeah, do you staff like a one-to-one, like say your rural population, do you have like a full-time, is it a BHC or BHCM or multiple BHMs? How do you do those ratios so that you have someone available for the warm handoff that's maybe not already full with a panel of CoCM patients and scheduled? Like, how do you figure that out? So you've got the accessibility piece. Is it two folks, or are they interruptible? I'd love to see how that looks on the primary care side.
Yeah, right now, like I said, we are in the beginnings of this. Right now, our clinic that is really rocking and rolling has one behavioral health care manager and one behavioral health consultant. So the consultant is there in person, gets warm handoffs, and really does a lot of triage. And if the patients look like good collaborative care, then he'll get those to our behavioral care manager. She's off-site. She works in the northwest corner of the state, and she does all through telephone. And then she works closely with our psychiatric consultant, and they staff those patients together. So I mean, right now that's how it is. Now, our goal is that, you know, if for some reason he's not able to keep our care manager full, then she would cover multiple clinics. So he kind of stays in that clinic because he's embedded there. But if, you know, if she can only get 30 or 60 patients from that clinic, then eventually she would go on to cover another clinic as a care manager. Does that make sense?
Yeah, that makes a lot of sense. And then the day of for the primary care visit, they do the warm handoff, meet the BHC. Are they doing that functional assessment at a different time? Like come see me tomorrow for the full assessment, or like, hey, if you got time now, let's do it right now. How does that look with their scheduling of the BHC's time?
I mean, right now in that clinic, he is really busy and we're not ideal. We're just starting out with the care manager. We're trying to offload a lot of patients that he's seeing regularly on her so she can keep up with them, and then he has more time. I mean, ideally he does the functional assessment that day and starts with the patient. You know, if it seems like, oh, this, you know, he sees them and they look like a good CoCM patient, then he might not do a lot. Just kind of introduce and say, hey, I've got this person, behavioral care manager, who's going to work with you, and I'm going to have her give you a call. And then she would do she would do the assessment, because it's a better use of her time than him doing it if she's going to be following him.
Yeah, no, that makes a lot of sense. Does he stick to that kind of traditional PCH, like then see them for maybe a handful of follow-ups, like 3, 4, 5? What is if the upper pathway in your workflow for brief intervention, what does the follow-up look like for that?
He likes to hang on to his patients, so we are encouraging him to let them go into specialty care if they're not getting better, or even not getting better, but if they are continuing to need a higher level than he needs to be providing. They are in that Batesville clinic, which is kind of north central, and you know, there's just not a lot of resources. So he does follow a lot of patients, and you know, we are working on trying to offload his schedule a little bit so he's more available. He's also incredibly embedded in the clinic, and so the doctors keep him busy, and you know, him being not always available all the time isn't a hindrance to him getting referrals because he's so much a part of the culture of the clinic. So you know, it's very personality wise. So you know, another clinic you would see lower referrals because that person's seeing patients a lot, but because he's so embedded, like they'll come and find him and make sure that he talks to this patient or make sure that they get on his schedule, or so I think it really kind of depends on that.
Yeah, okay. Oh, I see Kristen had a good question. I was thinking that too.
Yeah.
Sorry, I'm taking your thunder, Kristen. How do you
You're good.
No, Kristen, you want to come off mute and ask your question? It is a really good question and fits right with that workflow that Tisha was just showing.
Yeah, I was just curious, Tisha, how do you manage consent? If it sounds like the BHC is doing triage, are PCPs just sort of consenting to CoCM for all patients? Like, how do you do that?
Yes. So we have adopted the kind of universal consent. They are supposed to, if they are sending somebody to him, they are consenting the patient so that we don't have to worry about going back and getting them. That is starting to tick up. Monica will be happy to hear. And we've also been more, you know, we had our care manager. She, if she had patients that she's been given and there's not a consent in there, she'll go back and message the doctors and have them do the consent. So, you know, it's kind of a back and forth, but our policy is, and we are working towards that consent being, if you feel like that you want to involve behavioral health, then get the consent for the patient, so we don't have to worry about that depending on what pathway they go on.
So the PCP is doing that step.
Yeah, the PCBs. Stacy?
She's coming.
Thank you.
There you go.
Thank you for sharing this. It's great. I'm just curious. I've heard of some organizations that have that bill 90791 for that initial visit for the assessment. even like starting out with CoCM. So they'll bill like the regular code and then enroll and get them going with CoCM. That doesn't sound like the workflow here. It sounds like if it's identified that they'd be good for CoCM, then the behavioral health care manager meets with them and does the assessment. I guess the question is, are they billing like under CoCM for that assessment and initial assessment, or are they billing under the 90791 and then into CoCM from there? Did
So
that make sense?
we don't use the 90791. It's whenever it was kind of everything was built up in 2015. They really just started the workflow process with just using psychotherapy code, so and not the evaluation code. So we don't use 90791 for anything.
Oh,
So the billing would really would be who did it. So if the care manager does the assessment, then those minutes would be under collaborative care. If the behavioral health clinician did, a longer assessment, they're supposed to do an intervention with that, and they can bill a psychotherapy code. So I'm not saying that we're not doing it the best way. We're definitely exploring different ways to do it. And I have some arguments for doing the 90791. We bill incident too. So our care manager, our behavioral health consultants are not impaneled. They are, they're licensed, but they're not impaneled. They bill under the physician. So that might be part of it too. I'm not sure you can bill a 90791 under a physician.
Got it. Sounds like there's all kinds of ways you can do this.
There's so many ways.
Hey, Tisha, there were 2 other questions. Do you want them now?
Sure.
Okay. David, do you want to ask your question?
Yeah, sure. Looking at your flow chart, the most interesting point to me is the weekly MH consultation and scheduled interventions because of the ins and outs between behavioral health, brief intervention, measurement-based tracking, like no improvement, and so on. So could you talk a little bit more about the ins and outs and the rules around the weekly consultation?
Yeah, so the way that I've created this bottom part is like this bottom flow is is like a collaborative care. So the weekly consultation is the weekly psychiatric consultation with the behavioral health care manager, and the scheduled interventions are the calls that the care manager does with the patients. This is a flow sheet that I've made for our clinics, so for our doctors and clinics to understand. So I tried to use like non-jargony language just to help them understand this is what the patient is getting. So enrolled in, this is all collaborative care. And then this is more of the PCBH kind of track where they don't necessarily come in contact with the care manager or the psychiatric consultant. The care stays with the behavioral health consultant.
Well, the interesting part to me is the going back and forth between the 2 tracks and what sends patients one way or the other. And the fact that you're flexible, I think that's fantastic.
We want to be. I think that, I feel like that patients could benefit from both, and or, something's identified, and then they can be a good candidate to do, the other. And so, the BHC might be doing an intervention with the patient and then just be like, what, this patient will really benefit from being able to talk to the care manager every week and to track their PHQs and to be able to, have some help in, setting some real goals. And they would do better working with this person than with me right now, or I'm really busy, right? I got all these really severe patients I'm trying to manage. And so I'm going to have her help me with these patients. And then vice versa. Like we do have some patients that are engaged in both because, Monica's been to Batesville, and we know they have a very complex and really lots and lots of needs in that clinic in that community. So we do have patients that are, we're really just, we're trying to keep them like stable and, you know, trying to give them everything we can give them to help them get better. And so they benefit from working with Nathan, who's our behavioral health consultant, and they also really benefit from getting touches from our behavioral health care manager and getting information about medication from our psychiatrist.
It's just a testimony to the power of the blended model.
We think so.
Tisha, there's a question from Steve.
Mhm.
And Steve, do you want to ask it? Are you able
Sure,
to?
yeah.
Okay.
Just wondering about the availability of the psychiatric consultant to actually see a patient for a consult. In the case that the patient is a conundrum diagnostically, or there's some other reason that you want the psychiatrist to actually lay eyes on the patient, is that a opportunity?
Yes, we do that. Our psychiatric consultant really likes to see patients if she, you know, if it's needed. So we'll schedule it. It's a virtual visit, so she is able to see them virtually. Usually they come into the clinic, and we have the ability for them to be in front of a clinic monitor and see her there. And we found that to be really helpful.
And as a follow-up, is that something that's a common occurrence, or is that just a once in a blue moon thing?
It's more of a once in the blue moon. Like, we definitely do not do it for all the patients. It's really like whenever in order to make a good recommendation, she feels like she needs to interact with the patient, and she needs to lay eyes on them, and kind of get some interaction. You know, sometimes it's just really hard hearing from someone else about someone whenever you're trying to make a diagnostic interpretation. And she has a really good relationship too with our doctors, and so like they'll contact her directly and ask questions, and she loves to interact with them that way.
That's helpful. Thank you, Tish.
So I'm going to go on a little bit, just kind of give you a little bit of an idea of some of the projects we've had kind of building on this. Again, this is the ideal. We are not doing all of this in all of our clinics right now. This is kind of our vision that we've set for ourselves. We're doing it closest to that in Batesville right now, a little bit in a couple of more clinics, and we're building right now. So the first thing you remember from the beginning, we talked about how we started out with a good base. We had a team of people, but we were kind of operating as two different programs. We had our regional program and our central clinics. And so when we first got together, we decided that the first thing to do is to kind of build a team. So pull this all together and make us feel like, all right, we have this shared vision and we're a team. So I got a Blue Cross Blue Shield Blue and You grant, which gave us money to help develop some trainings, have some marketing, get some consultations. So we consulted with CFHA and trying to get some ideas of, okay, how do we take what we have and make it closer to what we want. So we had some trainings, we had some team building. You'll see our team here. We kind of built some processes for us to communicate regularly. So we built a kind of a Teams chat. We had some times when we came together, and the grant paid for that so that we could pay for travel and some food. And really kind of worked for a good year on, let's all, you know, learn together. We're trying to building a base for everybody feeling like they're a behavioral health consultant and that they have this role as a team member in the primary care team. We also got some swag, and so we have tags that say BHC. We have water bottles and pins and t-shirts and clipboards, And these have been really helpful in like when we go and do talks to our doctors and we talk to residents to just have some stuff. My regret, and if you have the opportunity to do this, is we had some really fun little bauble things that you play with, and we ran out of those real quick. And those were the most popular things. So little squish things that you can play with, people love. And so if you get an opportunity to get some of those, just get a million of them, because you'll run out quick. But we had our marketing team at UAMS make a logo for us. So the UAMS Behavioral Health Integration Team, that didn't happen, and there was none of that, didn't exist at UAMS until we kind of created this campaign. So we have a shirt, we have things that have this on it, and we kind of have an identity as the behavioral health integration team. So we did trainings. We did 4 trainings in person, and worked with C of HA to kind of build and create what those trainings would be. And we used the competency measure, and we showed that our people who did all the trainings increased their competency in being behavioral health consultants. So that's helpful that they learned some things as we did our training. We wanted to solidify our processes and to have people kind of acting the same way across clinics. And so if you remember, those encounters in 2002 were all over the place. We did a lot of different stuff. We sent letters, we did phone calls, we did a lot of stuff that was not face-to-face patient facing. And then as in 2023, you'll see that it was much more consistent. Almost everything that we did was what you call like a face-to-face psychotherapy intervention. We still did the other things. It's important. We don't want to stop communicating with patients in other ways, but we did kind of change the way that we practice and interact in our clinics. And 2024, this trend has continued. So it's kind of some of the outcomes we're looking for. Are we kind of coming together as a team and doing things in similar ways across clinics? These are just looking at the psychotherapy targeted interventions. So the blue line is 2022, the orange line is 2023, and the gray line is 2024. Obviously there are ups and downs, and we've had times whenever we are lower staff than higher staff. So these are just general kind of lines, but what we will notice is if you look at the cross, there are general trends for going up, and I think this is continuing to add up. I haven't added July and August onto this one yet. So what we want to do is to continue to increase the number of interventions that we're providing to patients. So our continued way to kind of build our team is we do monthly staffings with a CE opportunities. So we're continuing to learn together and make sure we all kind of have a baseline of things that we're learning. We've been going through the PCBH book together, and I work with Kathy Amons, who is the regional programs manager, to travel to the sites and regularly to get to talk with everybody and do in-services and talk to the residents and continue to build those relationships. And also continue to search for learning opportunities that our group can do together. Because I feel like the more we kind of have a shared language, shared knowledge, the better we will be. Our next phase was introducing and integrating, implementing collaborative care. You'll see a familiar face here. That's Monica. We got a grant to work with the AIMS Center to fully implement collaborative care in our Batesville clinic, and then to start in our internal medicine and our Pine Bluff clinics. And we had lots of training, and they came and did an implementation site visit with us, and really, I think helped bring us to a closer to where we wanted to be in 2023. And this is just one kind of data point. If you'll see, like November, December, January, this is all 2023. Really, we weren't consistently doing psychiatric consultations. We weren't documenting things. It was kind of willy-nilly. And then as we started working with them and getting our processes in place, nearly all of our patients were receiving regular psychiatric consultations. So in our collaborative care model, we were building onto that. And then our next big step is that the state of Arkansas, with UAMS as a site, is got a $10 million grant to implement collaborative care across the state, and we are using that money to implement across all of our sites. And so we get, as UAMS in the service line, we get about $1 million to $2 million a year for 5 years to hire behavioral health care managers, support implementation. And currently we have 2 behavioral health care managers with 43 enrolled patients, and it's continuing to grow every day. And they've been on board since July. So where we are right now, I feel like the facilitators that we've had here is supportive leadership. We do have supportive leadership, a great team. I have amazing people that I work with. We've built relationship. I feel like there is healthcare and policy momentum in talking about integrated care, talking about the need for behavioral health. Challenges, staffing, hiring, salaries. We've had a lot of turnover, especially in our behavioral health consultant roles. And so a lot of that up and down is, well, we don't have people in 3 of our clinics, and then we have people in 2 of our clinics, and 4 of our clinics are empty. And so it's really a challenge to staff. This is new territory as far as billing, payments, all these questions about, do you do 90791, and how do you bill this, and where does this, and our billing department, they are primary care, and they're also the hospital. And so, they're not really versed in these things. So I've told you a little bit about where we are. So just lastly, for me, takeaways are, we've had many, many, many setbacks, discouragements, spinning wheels, continued roadblocks. We have lots of difficulty with getting our Epic built the way we want it to really support us, billing challenges, turnover, and just every single one of our clinics has its own little personality. So, just tweaking and making sure that we can get our personalities on board is a daily adventure. Also for me, I've learned, it takes a village and continued discussions. As you see, for us to get where we are, we have consulted with CFHA, we've consulted with the AIM Center, we have brought in outside support and people to kind of help us think through all of these really complex ideas and to really help us. I also feel like that gives a little bit of legitimacy sometimes. Like, it's not just me all the time saying the same things over and over again. I've got people from University of Washington and from all these other areas that are saying similar things, and just keep beating the drum. We did not have salary was really low for our behavioral health consultants when I got here, and it's been 3 years, and they are getting a raise as of January 2025, which I think is going to help a whole lot. But it was a 3.5-year process of, we cannot sustain this. If you want these people in these positions, we have got to pay at least, what people outside pay. We cannot, I cannot keep good people if we are not paying them at least market. So, continuing those conversations. And that is all I have.
There was a question, Tisha, and I know we have like 4 minutes. There was a question just around, from a finance perspective, is your behavioral health integration, is it its own cost center, or is it part of the primary care cost center? Like, kind of how
It is
that's working
part,
for you
it's part
guys.
of primary care, right now. And, we operate at a loss. Our whole primary care operates at a loss. We're part of a larger system that kind of supports primary care because it sees it as kind of a feeder to our specialties. But we are really working hard towards that not happening. I really believe when I look at the numbers and I look at the potential that we don't have to be operating at a loss. But it's a process. So that is definitely my goal, is to be operating at least just supporting ourselves. We don't want to be on the chopping block.
Was it challenging to get buy-in and FaceTime with your leadership team, your C-suite, your CFO, whatever? I sometimes struggle as well, you're a physician, stay in your lane, you're a PCP champion. I'm like, but somebody has to have that big view of what's coming in and what the program's costing and what it benefits. And it's sometimes hard to kind of break down silos even in your own shop. So.
I would say for me, it's not been difficult getting like in front of people. Like they've been like ever since they brought me on. Like I feel like I've been at the table. They're interested. I mean, I do think that we can definitely, and something in one of the slides I skipped, that you get lost in the shuffle. We're small. We're a little group compared to all the physicians, and the money that you're talking with us is not nearly as much either. So you're talking about $1 million versus $20 million. It's really difficult to kind of get like, oh, well, can we do this? So, in some ways I feel like can be a positive because we kind of just continue to be written because we're not huge. But then, sometimes it's like, well, we want to be operating at the highest level we can. And we would, if we had a little bit more push behind us, we might, it may not take nearly as long as it does. Did that help?
Very much. Thank you.
And I
All
will say, I
right.
feel like that one of the reasons why we've had any success is because of the support we have. I feel like that not much could happen if you don't have leadership that's on board, at least to say you can do things.
Fair enough. All right. Well, we are at time. So it was good to see y'all. I don't know if Tisha's hanging around, if there are more questions.
I have an
Jan,
interview with a behavioral health care
oh,
manager, so
all
I
right.
gotta
Adding to the
hire two
team.
more.
Adding to the team. So adding to the team and then get the caseloads up. Well, I hope all of you have a amazing day. Hope to see a lot of you at the conference. If not, then we will see you. I don't remember the date right now off the top of my head, but the first Wednesday in October. See you guys then.